Good morning, good afternoon, good evening, depending on where you're. Welcome to Africa briefing on other emergencies in Africa. Weekly engagement with members of the media about update health issues, particularly the Mpox, other health emergency, as we've mentioned. Today we have with us Professor Yap Boom, who is the Deputy Incident Manager of the Incident Management Support Team sitting in the Democratic Republic of Congo. He's joining us to provide us the update on the emergencies across the continent. Just before we turn over to Prof for the presentation today, let me remind our colleagues that you can send in your questions to our WhatsApp number that is on our media advisory. You can also send in your questions through the Zoom Q&A portal, and you can raise your hand live to ask a question and interact with Prof and the team at the IMST doing the section for question and answer. At this moment, I will turn over to Prof for today's briefing section. Over to you, Prof.
Thank you, Nick. Good afternoon. Good morning, good evening. I'm pleased to convey you today for the press briefing on behalf of our Director General, Jean Kaseya, who's currently attending the World Health Assembly in Geneva, which is a critical moment for the health of our planet. So before that, I will pause a bit as the outbreak is spreading in West Africa, as I will present, to appreciate the effort of all the colleagues who are working tirelessly, long hours, not minding their weekends, not only on Mpox, but all the other outbreaks. So I really want to send our appreciation on behalf of the IMST and on behalf of the DG as we start this conversation with the journalist. Over to you, Nick. Thank you. As mentioned, the World Health Assembly has started this week and will last 2 weeks. It is really a critical moment where the global leaders on the health space, but also the financial space and many others convey to discuss on the future, the present actually, of how we respond to outbreak, how we manage our health, and therefore it's a critical moment. So there have been some important meetings, as you can see. Our green paper has been handed over from our DG to the DG of WHO to push the agenda of the health financing reform, the need to strengthen health system, but also to reaffirm the vital collaboration between Africa CDC and WHO. The IMST is one of the products of this collaboration, but there is much more that is ongoing where the two organizations are willing to carry on the global support and alignment to ensure that our population are protected as health is concerned. Next slide. In parallel to that, there are quite a number of activities, and our DJ was promoting our shared vision on locally led and sustainable solution. Africa CDC is championing the local manufacturing agenda for vaccine, for product, and this has been part of some of those discussions to emphasize the urgency of locally led response, because the response, the solution need to be homegrown so that they are adequate to the challenge that the continent is facing. And that call for an increased investment in African-made health products And to achieve that, there's a need to remove the systemic barriers that continue to hinder the regional manufacturing and innovation. And that cannot be achieved without the health sovereignty and African leadership. Next slide. During the Health Assembly, especially at the early stage on Saturday, Professor Mohamed Janabi has been elected as the Regional Director of the World Health Organization African region. He has been congratulated by our Director General, and we believe that he will carry on strengthening the strong collaboration that we currently have between Africa CDC and WHO Afro as part of the IMST to fight against Mpox and other diseases, but as part of many other activities that we are all implementing in the continent. Next slide. On the side of the meeting as well, the issue of strengthening equitable access to health products has been part of the key discussion. And we are happy to celebrate the partnership that we are sealing with UNITED to advance health innovation, manufacturing, research, and preparedness across Africa. And with Fiocruz from Brazil to scale up the manufacturing of diagnostic, therapeutic, and medical oxygen, relying on their great experience that they had in Brazil and the way they have been able to support all the Latin America. Next slide. Now, coming back to the public health event. As you see, there are quite a number of those high risk, moderate that we are facing in a weekly basis. The top 5 are led by cholera, which is affecting 20 member states with 100,015, 513 suspected cases since the beginning of this year, and more than 2,000 deaths. This is followed by Mpox, measles, dengue, and Lassa fever. This is just to give an idea of how our warriors are fighting in different fronts with the member state to address those high risk, moderate risk outbreak that the continent is currently facing. Next slide. Coming back to the Mpox situation in the continent, we have a mixed flavor where we can see the decrease or the stabilization of the case notified, a small increase of the confirmed case, as you can see, 1,073 as compared to 1,033 last week. The death on suspected case also are slightly increasing while the one on the confirmed case are decreasing. The good news is the completeness. All the countries are actually reporting, which is emphasizing the great work that the surveillance team in the countries are implementing, but also the strong collaboration and coordination that is happening at the continental level. Now, this week we have one new country, Togo, we'll come back to that, that currently has reported 3 new confirmed cases, while Ghana, that has been in control phase, has also reported 4 new confirmed cases, which means the West Africa currently is also of concern, looking at the spread of the Mpox in those countries. As we see, Sierra Leone is still leading the trend of the outbreak. Next slide. As mentioned, when we look at the 12 top countries that are reporting cases currently in the continent, DRC, Uganda, Sierra Leone account for 95.5% of all new confirmed cases in AP week 19. But we can see some gradual increase in Kenya, in Zambia, and in Nigeria. Next slide. As Sierra Leone is concerned, we've mentioned that 61% of the cases are currently coming from Sierra Leone. This is of high concern. Next slide. So going back to West Africa, Togo, this is the first time that Togo is reporting a case. On the 16th of May, the Minister of Health declared the outbreak following the confirmation of one case, and as per today, we have 3 cases. None of them had travel history to any of the country currently reporting confirmed case. However, one of the cases had a travel history from Benin, though Benin has not yet reported any confirmed case. We commend the country to implement a swift response, and we are happy to see that there are already 55 contacts listed, which means an average of 18 contacts per one case, knowing that the ideal is to have 20. So we really appreciate and support the country moving toward that. The clade 2 has been sequenced, knowing that this clade 2 is the same that we are currently seeing in Sierra Leone, but also in Ghana. So the IMST is working closely with Togo. After this meeting, our colleagues will be engaging the country to know better how to support the country and ensure that we control before the spread of the Mpox across the country. Next slide. Now, still in West Africa, Sierra Leone, definitely the most concerned country as we do speak. The number of notified cases are increasing. The number of confirmed cases as well. We are now at 658 cases in the week 19. The clade 2B is the one circulating. It's important to highlight that while in the central part and the eastern part of the continent, we are dealing with the clade 1B, especially in Uganda. In DRC, we have both clade 1A and 1B, and now we are seeing another epidemic, let's say another outbreak, currently spreading in the West Africa with the clade 2B. The testing coverage is good, 100%. The test positivity is quite high, which is an indicator that the patient come to the hospital when they already have some severe form, that's where they are detected, rather than being detected within the community. This is also showing that there is a suboptimal active case search. On the other hand, the health facilities are overwhelmed with more than 200 bed occupancy. Basically, that means that in some places, you have 2 people in the same beds. So there is definitely an urgency to address the issue on those different pillars. Next slide. In terms of response, the first thing, one of the key points to address is the diagnostic. You need to detect early enough the case. So to achieve that, support has been provided in terms of test kits for PCR, in terms of training as well, in terms of supporting the country to the decentralization of the laboratory. So the target is to have 8 labs, of which 2 are using PCR. And we commend the countries for the first in-country genome sequencing that was completed. Out of 23 samples, 22 were found positive and therefore sequenced with the clade 2B sublineage A22. Now, the country needs more support in the lab, still in terms of genomic, to ensure that at least 8% of all the positive cases are sequenced so that we can track, we can see which type of clade we are dealing with, and we can ensure that if there is a new mutation, we can capture it. But also, we need to support the country to improve the sample referral with the same-day transport so that within 48 hours between the sample collection, patients need to have the result and therefore being isolated, attended so that we can limit the spread of the disease. We have an important team who will be moving next week to Sierra Leone to support on the infection prevention and control, to support in surveillance, to support in vaccination, also to support in surveillance. That will ensure that the country has all the technical assistance prior to the actual reagent and goods and medical countermeasure to arrive and to be implemented so that we can stop and control the outbreak. Next slide. Going back to DSC where we currently are, it's first important to highlight that there is a data harmonization. So the team is working hard at the national level to ensure that the data that we do have are of high quality. That's why you will see that the number of suspected cases has reduced because this process is still ongoing. In the confirmed case, we see an important reduction from 29 to 117 last week. However, we still have the challenge of the testing coverage where the number of suspected cases out of 10, we have maximum 2 which has the sample collected and tested, which means we don't have a clear picture of what is actually happening on the ground. We are happy, however, that the situation is stabilizing in the North and South Kivu, where activity of vaccine has actually resumed, as I will be showing a bit later. Next slide. In Burundi, the reduction is continuing with 80 cases notified as compared to 125 and confirmed 27 cases out of 24 last week. The test positivity rate is 33%, which means that the active case is moving on well. But the country has decided to move even forward to achieve the 0 case. That's why we are supporting the retention of 200 community healthcare workers so that they can carry on the surveillance at the household level, but also the communication and the integration on the national system of surveillance. Next slide. In Uganda, we are kind of challenged because we were seeing the decrease in the number of confirmed cases. Now, for the last 2 to 3 weeks, we are seeing some increase. Currently, Uganda accounts for 22% of all the confirmed cases in the continent. The home-based care has been introduced because the bed capacity at hospital is being overwhelmed. But this has to be done with a great support on ensuring that the infection and prevention control measures are adequately implemented so that the people who are taken care at home are not super spreader, contaminating the people around themselves. HIV is still leading the death. Therefore, the integration that the country has started, including people living with HIV association, STI association, is really the way to go. Therefore, this population will be the one highly prioritized in terms of vaccination, in terms of prevention, so that we have an impact on the reduction of the case fatality ratio among that population, which is the highest in terms of vulnerability. Next slide. In terms of vaccination at the continental level, more than 1 million doses has been shipped to the countries, as I will show later. More than 722,000 doses have been administered. And we commend the countries for the approval of the vaccine and the extension of those approval. As DSC is concerned, 529,000 people have been vaccinated, and they represent 81% of the persons vaccinated across the continent. As mentioned, the good news in the South and North Kivu is that some activity are resuming, including the targeted vaccination. which happened in Kinshasa in the IDP camps, but more importantly, in the South Kivu and the North Kivu. In the South Kivu, more than 1,000 people have been vaccinated over the week. In using the target vaccination, I think it's important to remember what it is. This vaccination is the one which is occurring around the case. You have one case, you locate all the contact, and those are the people and the contact that are prioritized. You also have the people who are at high risk in terms of exposure, but also in terms of risk of transmitting the disease around themselves. Those are the people that are the main target as this strategy has resumed in the Kivus. So far, the children still represent 22% of the total people vaccinated because they also account on the patient that we are seeing in this outbreak. Next slide. Still in the vaccination, we have 11 countries that have received vaccine. DRC granted the AU extension, the 6th of March. The continental vaccine needs is 6.4 million. So we have already received 1,300,000, but we are still far from what is expected. One, to control the outbreak, but two, also to reduce by half Mpox in places where it is endemic. It is important to think about countries like Central African Republic and some part of DRC like the Equator, where Mpox has been there. And because we have not been able to solve that, how we have those mutations. So it's important to also ensure that we implement the vaccination in those places and reduce by half, as mentioned, the burden. Readily available, we have more than 300,000 doses that are available. Unfortunately, the funding for those is not yet available. So as per now, UNICEF needs 23 million of US dollar to acquire those vaccines and therefore supply them in countries. As for DRC is concerned, the LC16, the other vaccine, 1.5 million doses are expected by the end of this month. The preparations are ongoing, and this will definitely be a great support and hopefully a great impact on the fight of Mpox in the countries. But still, though the doses are important, it will still require this target approach, especially now that the improvements are being made on the side of surveillance. Next slide. Now we are moving to cholera. Remember, I mentioned that cholera is the top in terms of number of member states exposed, but also in the term of number of cases. You have a list of some of those countries: Angola, Burundi, Comoros, DRC. Those are the countries that are affected. Next slide. But the top 4 countries are DRC, next slide, Sudan, South Sudan, and Angola. Those countries still represent 84% of the case and 92% of the death, with a high fatality ratio, more than 2%. And as you can see, all the region of the continent are exposed. The Eastern Africa, led by Sudan and South Sudan, the Central Africa, driven by DRC, the Southern Africa, driven by Angola, and of course, the Western Africa, where we also have the spread. And the seasonally pattern presents an opportunity for intervention. A better understanding of the season should equip us to better prepare for that response. Next slide. Zooming a bit in Angola, we can see the decrease into the number of cases over last week. Over 200 cases have reduced, 9.7% decrease in terms of number of cases. But still, the case fatality ratio remains high, more than 1%. And to really carry on the decrease, to control this outbreak, a multi-sectoral approach is needed. Next slide. As you see from those challenges, it's come back to the fact that cholera is not only a medical challenge, is a challenge in the inadequate access to clean and safe water. That's the reason why the multi-sectoral approach is critical. Yes, we need the medical countermeasure in terms of protective equipment, in terms of protocol to take care of the patient, but we need to have water available for the population. If we don't have that, it would be quite next to impossible to solve the issue of cholera. Next slide. Now to summarize, we are going through a critical time. We have 2 intense weeks when the World Health Assembly is taking place. This is also the place where new partnership, very strategic, are happening in terms of reshaping the financial ecosystem, but also accelerating the local manufacturing of emergency countermeasure. As Mpox is concerned, the disease continues to spread, expanding to West Africa, Togo, Ghana, with a different clade, highlighting the fact that we are dealing with a mixed outbreak. While we are dealing with the clade 1A and 1B in Central and East Africa, in the West Africa, we are dealing with another clade, another way of transmission, another challenge, and therefore the response needs to be tailored. Sierra Leone definitely showing an exponential growth in case over the past weeks. The teams will be supporting next week to ensure that the country has the support that they need. In Uganda, the deployment of the target vaccination, the 3rd round is starting, and it will hopefully comfort the good result that we've seen in places where the vaccine has been used. The cholera crisis led by Angola, Sudan, South Sudan, and the DRC are highlighting the need to have a multi-sectorial approach, and more importantly, as we do for Mpox, a regional and coordinated approach to address the burden of cholera in the continent. Over to you, Nick.
Thank you, Prof, for that very informative briefing section on the health emergencies happening on the continent. At this point, we're going to transition into our question and answer segment, where our colleagues, the journalists, can ask questions. And the way you do that, colleagues, is you raise your hand using the raise hand icon on Zoom. You can also send questions to the Q&A icon on the Zoom platform, and as well in the chat box. Our colleagues we are roaming in the different segments to be able to get your question come through to Prof for response. So let's start with those who have raised their hand on the platform. I've got 4 colleagues who have raised their hands. Let's remember, colleagues, this section is for journalists, so we want to give the media colleagues the opportunity to relay the information from here to the public. Just before we take the first colleague, let's remind colleagues that this section has the interpretation. The meeting is simultaneously being interpreted in French and English, so you can pick on the interpretation icon, you can pick the language of your choice. So with that, we'll move into our question and answer section. Let's take Kamo Chen of Minor Reporter in Sierra Leone. Kamo, over to you.
Hello there. This is Kamo Chen. Dr. Yap, I wanted to ask, you mentioned the virus is spreading across West Africa. Now, I wanted to ask, have we identified or have we detected any link, epidemiological link between at least 2 countries or more, to tell that the virus is moving from one country to another? There is a second part to my question, and it's also about this the link. Here in Sierra Leone, for example, now that we are getting into this epidemic, officials are talking, and I noticed we recorded at least 1 or 2 cases of Mpox in 2022, but this was never, a public issue. I wanted to know, why is it an issue now? if we have been recording it, but now it's so much an issue and we are hearing cases coming up all over the place. What is the explanation for this? Thank you.
Thank you, Kamo. So, Prof, that's 2 questions from Kamo. Let's take another colleague, Paul Adepuchu from the Lancet, and then we will move to Prof for responses. Over to you, Paul.
Thank you very much for this opportunity. My first question has to do with the Africa CDC's current engagement at the World Health Assembly. How would you describe a successful outlook for the Africa CDC at the Assembly? And what insights can you share regarding the direct interactions between the leadership of the Africa CDC and the incoming leadership of the WHO African region? I also have a question regarding Sierra Leone. Do we have insights into what is uniquely driving this current outbreak? What insights can you share with that around the demography? And last question, you gave data talking about Africa has received 1 million doses out of the expected 6.4 million doses. How would the Africa CDC assess the pace of the rollout of the vaccines that it has already rolled out, that has been already rolled out across the continent? Are we satisfied, or what do you think is still delaying the quick rollout of these vaccines? And can we describe and compare the early impacts that these vaccines are actually making on the overall outlook of the outbreak compared to other public health measures like informing the public? So thank you very much.
Thank you, Paul. Over to you, Prof.
Thank you so much, Kemo and Paul, for the question. So I will let after Dr. Messi answer the question about the link between countries in West Africa in terms of the case. And you're asking, why is it an issue now? Why is it an issue now in Sierra Leone? It's the way we declare, the way we manage our epidemic and outbreaks is we have a level, a threshold, a number of cases that is considered normal or acceptable in countries where the disease is endemic. One example, if every year through the surveillance, the great surveillance that is happening in Sierra Leone, if every year they report 10 cases of Mpox, we consider it part of normal. If in DRC, in the Equator, they report 100 cases every year, we consider within the normal. Same thing for CAR, because those are the countries where this Mpox is endemic. Now, when you go beyond the threshold, when you move from 10, now we have 1,000, more than 2,000 active cases. Then it becomes of high concern because we are moving from the routine, what we are seeing and expecting, to an unusual increase in the number of cases, which has implication. As you know, in Sierra Leone, the bed capacity, though we are pushing to increase it, has been 60 beds. And if you have 60 bed capacity and you have more than 1,000 active cases, the system is stretched and overwhelmed, where you now have to put 2 people in the same bed, which is not acceptable in a normal situation. You also have other implications in terms of the visibility, the global visibility. It may have some economic implication where people may be scared to come in a country because the disease is happening. So this is why when we move beyond a certain level, we have to be more careful, move from the routine to the epidemic, to the outbreak mode, where we have to deploy all the cascade response that we are seeing currently. To Paul, yes, Professor Pajani from Tanzania has been elected as the new RD, the Regional Director for WHO. And through the first conversation that happened with our Director General, with him and Dr. Chikwe, who is the acting RD, we will carry on and even strengthening that partnership. because having the two institutions, WHO and Africa CDC, hand in hand, as we do currently here at the IMST. Remember, the IMST is a collate by Africa CDC on one side, WHO in the other side, sitting in the same environment. So this spirit is what we will strengthen, especially at a time where the resources are limited. So we have to do more, better with less. And that goes with mutualizing of the resources that are available. For the driver of the outbreak in Sierra Leone, Dr. Cheng will come to that. On the side of the vaccine, yes, the plan that we have is 6.4 million doses of vaccine. And this is, again, important to highlight to control the outbreak and also to reduce by half the burden in places where Mpox is endemic. We really look at both. Now, we are grateful that we've managed to ship 1.3 million doses of vaccine, thanks to all the partners who have been working within the IMST, UNICEF, WFP, Gavi, and all of them. Now, are we satisfied by the pace of the shipment of the vaccine? A tremendous work has been done. I think in terms of indicator, they are getting almost 100% of what was expected in terms of shipping the vaccine. In terms of the vaccine absorption in countries, also is pretty high. There has been some challenges. You know, having the vaccine in one thing, having what we call the operational cost to make the vaccine deliver to the last mile, we need some of those resources. And they've been made available through the support from Gavi, but there has been some delay, which has delayed the vaccination in some countries like Nigeria. But when you go to other countries like Uganda, 72,000 of those of vaccine has been used out of the 111 that they've received, and the third round is starting this week. If you come to Sierra Leone, where they've received 58,000 doses of vaccine, much more than half has been used, and I think as we do speak now, 11,000 doses are remaining. And they are actually asking for more because seeing the spread of the disease, there is critical need to have more vaccine. And we are glad that the conversation happening around the WHO World Health Assembly are also moving toward finding the solution, finding the vaccine for Sierra Leone and other countries. So are we satisfied? We are making progress. If we ask me the impact of the vaccine, there are studies ongoing, which we call vaccine effectiveness. They are moving on when we hope to get the results soon. But before that, when we look at the healthcare workers who were the first to be vaccinated in DRC and other countries, we have seen a drop in the transmission, thanks to the IPC, but also thanks to the fact that they have been the first one vaccinated. If we go to Uganda, and the report that we got from the SN commander is that in places where they eat the vaccination with a targeted approach, it has been a strong decrease in the incidence of Mpox. So yes, we are moving forward. Now, the vaccine is surely not a silver bullet, not. If you go to Burundi, the country has managed to control the outbreak without the vaccine, but they have other ways of implementing within their context. They were able to isolate all the positive cases on time. They were able to decentralize as soon as possible, and they were able to have the sample tested within 48 hours. It is possible in Burundi. It might not be possible in DRC because of the logistic, because of the environment, because of the security, because of the other drivers. So now I will let Dr. Messi answering the question about the link between the countries in West Africa and also the driver of the outbreak in Sierra Leone.
Thank you so much, Professor Yap, for those insights. And thank you, journalists, for the fantastic questions. They're really quite pertinent. Starting with the issue around the link of the CLIT with other countries, looking at it from Sierra Leone and where there are links with other countries. CLIT 2B actually follows a very, very peculiar, space in terms of how it's been transmitted, and mainly being human to human. And the 2022-2023 outbreak has mainly been due to human transmission. And definitely there's actually been exportation and importation of cases in several countries. And if you look at the Western African region, that's looking at countries that are currently being affected, like Ghana, Nigeria, Sierra Leone, they're all reporting CLIT 2B. And definitely if a country wasn't affected before and it's now being affected, it definitely could be possibly due to the importation of the case. And the fact that the source of exposure has not been identified does not necessarily make it, an in-country exposure. It's not 100% that it actually spilled over from, even though it's a zoonotic, spilled over from animal to human. It could also be a case that was exposed in another country, but definitely there's need for more investigation to be able to ascertain the source of exposure. But again, just to point our attention to some of the examples of cross-border spread, due to truck drivers. If you look at the eastern region where we had truck drivers moving into Uganda from DRC, and then you see the same from Tanzania to down south of Africa. And there's been some cross-border spread, and definitely some of those sources of exposures have actually been identified. But again, it needs a very good investigation as well as genomics, deeping into the potential of genomic sequencing to be also to be able to ascertain some of the sources. So yes, cross-border spread, and there's actually been documented links across countries. Sierra Leone is quite peculiar because even to date, I think the index case, it's the source of exposure outside Sierra Leone has not been established. So definitely there could be, that just shows that there could have been silent transmission ongoing for quite a while before it's been detected by the country. Then moving to the second question around the demographics, unlike in other countries where we are seeing a bimodal kind of spread across different age groups. For Sierra Leone, it's more shifted to the young adult population, mainly persons between 20 to 40 years are most affected, and then children less than 15 years account for less than 3% of all the cases that have been reported. That really shows that the lifestyle of that age group, of course, we know they are more or less very active, and also the fact that they are the ones who are mainly involved in most of the movements and all that really also puts them at risk. But again, key to mention is that unlike other countries that have really profiled, the professions of some of the affected persons, in Sierra Leone is a little bit tricky because so far the sex workers are really not coming out, but we're hearing about students, we're hearing of drivers, and things like that. But the sex workers that really comes out prominently in other countries, we're really not seeing that in Sierra Leone. But again, just to also highlight that the areas that are affected in Sierra Leone are really very densely populated. We're talking about the two districts within Freetown, including Western area urban and Western area rural. And of course, these are very highly dense, densely populated districts, as well as we also have slums within some of these districts, which are really overpopulated. And again, the wash facilities in these areas are really not the best. So definitely having high vulnerability amongst this population to spread. Now moving to the last question around the drivers in Sierra Leone, like I mentioned, it's happening within Freetown, and then we also have Mombali, and these are the areas that account for 91% of the population. And like I mentioned, the dense population in these areas, as well as the touristic attraction that it also poses for the influx of different populations within that area. So it definitely also makes that community and the districts really prone to the spread of the disease. And one last thing to just mention again is the fact that even the facilities, we're beginning to see spread, and high risk of, propagation of the disease, given that the health facilities are overwhelmed, and the IPC currently is compromised. So that's really a concerning situation that really needs more attention to be put in. Back to you, Prof.
Thank you. We can take more questions.
Yes, thanks, Prof. and Mercy, for the responses to those questions. Let's go quickly in the chat and pick other colleagues. We know we still have some colleagues who have their hands raised. We'll come back to you. Let's take this one from the chat from our colleague, James Konda. He writes for Anadolu. James says, has there been any progress made in the establishment of a humanitarian corridor in Goma in the Eastern DRC? So James is asking about any progress on a humanitarian corridor being created in Goma relative to the conflict and the outbreak. A second one, before we come to you, Prof. This is our colleague Sharif Sakat from Outpost Media, based in the Gambia. He says, as the cases of Mpox escalate across many parts of the continent, what can be done as a way of paradigm shift by Africa CDC to tackle the public health emergency facing Africa? So those are two questions from James and James and Sharif. Over to you, Prof.
Thank you. Thank you so much, James and Sharif, for those two questions. So as mentioned, the situation is stabilizing on the North and in South Kivu, where the humanitarian actor, but also some of the colleagues are actually resuming some of the key activity of the response. I mentioned the vaccination, where more than 1,000 people have been vaccinated in the South Kivu last week. So we also have our colleagues there, the field epidemiologists, who are actually working with engaging the community healthcare workers, because those people are the key to implement the surveillance, the detection, and also finding the people who are the targets for the vaccination. So this is happening, and then we hope that this stability will continue so that we can really grasp what is happening in the Kivu. As we do remember, this has been the epicenter of the Mpox in DRC. Now, from the colleagues in Gambia, I think is Sharif, the Mpox is escalating. What can be done? Two things. We have what we call the hotspot countries. Currently we have Sierra Leone, we have DRC, we have Uganda. In those countries, we intensify the response in the sense that we scale up the community-based surveillance so that we are in the community tracking the case, isolating them, implementing the proper prevention control, providing the good information to the community, and putting the ground to scale up the vaccination. This is what we need to do in those countries. Now, in the countries that are exposed, they are starting to have some few cases, and those who are around, we push on the response and the preparedness for those who don't have case yet. For example, a mission will be next week in Togo, so that the country is well equipped, though they have already started a very good response, as we see with the high number of contacts per case. I think it was around 18 for one case, which is great. So we need to go in those countries to support the implementation of the right approach to respond, while we are also strengthening the capacity to other countries in terms of preparedness. Over to you, Nick.
Thank you, Prof. Let's go to our colleagues who have raised their hands. We'll take 2 colleagues from there. We'll take Agnes from New Vision in Nigeria, and Agnes will be followed by Williminta Jabba from the LBS in Liberia. So Agnes, over to you for your question. Agnes, can you hear us? Hello, Agnes. I think Agnes is having a challenge with her connection. So let's take Williminta.
I am here.
Okay, Agnes, go ahead. We can hear you.
Yeah, thank you so much, Prof. And thank you for that good information. Yes, for me, I would want to know what's happening to Uganda. Yeah, you say you've been doing very well, but lately you've seen a spike in the cases of Mpox, the new cases of Mpox. So what's happening? What probably you could have found out what's happening, what is the cause of that spike, and which areas are most affected, the hotspots, and maybe what we were doing better that we are not doing now, and how you think we should be able to bring down the numbers soon. Then also when it gets to cholera, yes, I heard that our neighboring countries, Sudan is also reporting cases. So what happens to countries that are at the border, bordering the affected countries? Do you put in measures so that the diseases don't spread to other countries as Africa CDC? Over to you, Prof.
Thank you, Agnes. Let's take Williminta. Hello. Hello, Miss Jabba. Can you hear us? Okay. If you're speaking, you're muted. We can hear you. Hello? Okay, now
yes,
we can
hello.
hear you. Go ahead.
Thank you, Prof. My concern has to do with the issue of vaccines, looking at Sierra Leone, which is bordering Liberia, and the increasing waves of the Mpox disease in Sierra Leone. Currently, Liberia recorded 3 active cases, and there was a visit at the Liberia-Sierra Leone border yesterday by Enfield, and I was with the team. But then the director spoke about vaccines, that Liberia needs more vaccines. And in your presentation, I think you mentioned about if there are African CDC is planning to resupply countries that are bordering, countries that have increasing wave of the disease to ensure that the disease doesn't spread to that country. And I think Liberia is one of those countries, because Sierra Leone is bordering Liberia. So I want to know whether there is any plan from Africa CDC to supply Liberia with more vaccines, because our vaccines, according to the Director General of Enfield, is limited, looking at how citizens are pulling in to take the vaccines. And they are only targeting few people due to the limitation of the vaccines we have in country right now.
Thank you. Over to you, Prof. You can take Agnes and Williminta question. Over.
Yes, thank you so much. I will respond to Williminta, and I will let Dr. Cheng respond to the question in Uganda and cholera. So first of all, and again, it's important to remind that the vaccine is not a silver bullet. It is one key pillar which come and support the other pillar, which include the infection prevention and control, the surveillance, and others. Talking about that, we need to commend the Liberia Ministry of Health, Liberia government, for the leadership in supporting Sierra Leone through those activities as the one you've mentioned on the cross-border collaboration and coordination, but also offering some support in terms of laboratory and so on. Those kind of partnership It's really something critical for us as IMST and as a part of the Africa CDC. Now, specifically in terms of vaccine, the way it works is country make a plan. Based on the plan, based on the way they see the epidemiology growing of the disease, they make some estimation of how many doses of the vaccine they might need. Based on that plan, they submit to the IMST, which are what we call a technical review committee. And those people who are external will assess the demand compared to the epidemiology and allocate. That is how recently DRC has been granted 500,000 doses, Uganda 200,000 doses of vaccine. And as we do speak right now, the Sierra Leone has revised their plan, which is being submitted so that we can ensure that they have a new allocation because they have been finishing the 58,000 doses that they've received. So Liberia has also received doses of vaccine. So now it's upon the country, and we work close to the country. Today, Liberia was presenting at one of our meetings their response. And again, they highlight the issue of vaccination with the fact that they are close to Sierra Leone. So they will revise their plan. According to that, we'll see what the estimate they need, and then we'll find for the vaccine. But the challenge is there is a global shortage of funds to mobilize the vaccine. So we really need to do more and best with the few doses that we have currently as we push to mobilize much more doses, as the DJ is currently doing during the World Health Assembly. Over to you, Dr. Cheng.
Thank you so much, Prof. And thanks for that question. I see we are already out of time, but I'll just wrap up quickly with the response. So in Uganda, what is happening in Uganda? We have over 6,800 confirmed cases with 41 deaths being recorded. And this has been recorded in several districts. And so far, we are seeing that the urban centers and the fishing communities remain the epicenters of transmission, with Kampala, Mbarara, Hoima, and Masaka accounting for the majority of cases that have been reported. Initially, Uganda began with doing, just before even Ebola, we're doing quite well in terms of active surveillance, whereby we had community healthcare workers going down there to actively search for cases. But when Ebola came up, the system was overstretched, and then the focus on Mpox also declined. Accompanied, or in addition to the global freeze of funds, again, this was also really affected in that most of the districts began relying on passive surveillance. And by passive surveillance, what does that mean? It means that you sit in the community until you feel you're really that bad, then you show up to the facility after you've tried several options. So that also opens the window for spread within the community. So there's really been some silent spread going on. And while we're seeing an increase in it's due to Hoima city, the Hoima County district, that's now undergoing what we call active case search. And there's some intensification in that particular districts, and that's why we're seeing an increase in cases. But the other districts actually are quite silent, not because maybe there are no transmission ongoing, but because they are strictly relying on passive surveillance. And that's one of the things that we really need to ensure that before we interpret the decline of the curve as a true decline, we definitely should be on top of the game in terms of our surveillance initiatives. So, but for Sudan, and cholera, it's more or less spreading within South Sudan. We also have some cases, sporadic cases here and there in Kenya and other countries within the Horn of Africa. And definitely, shows the need for cross-border collaboration. And some of these, spread is being actually influenced by forced displacement, and we have refugees moving from from country to country, seeking for shelter, and this also propagating the spread of the disease. This definitely tells us that it goes beyond just the health sector. It needs a really whole of government approach, bringing together all the different sectors, looking at it from in external relation, bringing together all the different actors, looking at even the partners that are in charge of peace and security, and ensuring that we have all the different arms, including water and sanitation, Ministry of Health, coming together, and Ministry of Environment, to really look into this issue, because the Ministry of Health alone may not be able to curb the spread of cholera. Over to you.
Thank you, Prof. Thank you, Mercy. If you have time, we've got extra minutes to give you that you can respond to at least 4 or 5 more questions before we close our section, if that rests good with your time. So let's go quickly to our chat. Our colleague Charles Chikapa from CDC Media in Malawi asked a question. He says, China has announced a $500 million commitment to the World Health Organization over 5 years span, as the WHO grapples with budget cuts and reduced US contribution. What is Africa CDC reaction to this development? And then our second question in this piece comes from Liberia again. Liberia is currently facing the outbreak of Mpox. How can the Africa CDC support and equip local organizations like civil society group to provide awareness and risk communication for the country? So those are 2 questions from our chat. Over to you, Prof.
Thank you so much for those few questions. So for China, we definitely commend the solidarity and the fact that the member states are contributing more to WHO, which is one of the pillars of the Africa health financing in the new era, where we ask more domestic funding. So we appreciate that in the continent, Angola, for example, has pledged $5 million for Africa CDC, and also is contributing $8 million to WHO. So this is also a way how country can show the resilience to the fact that the USG has reduced their funding, and the fact that we mind for our community. So that kind of support is really appreciated by Africa CDC. On the issue of Liberia and the support of Africa CDC through civil society, this is implemented through the support we are providing to the National Incident Management System. They are the one at the country level who identify the key stakeholder to work with, and we just come in support. I think we can stop with those questions, and I hand over to Nick.
Thank you, Prof, for the very quick responses to those questions. We take the last 2 questions just as we close. The first one in this last 2 questions comes from Lisa Sharon. Lisa is with CDREP. She's an editor at CDREP based in the US. She says, can you share any more details about how Mpox is spreading differently in affected West African countries? And then our last question, just to close our section for today, comes from Zain Zaba. She writes for Bloomberg. Zain's question links to measles. She said measles is 3rd in the top 5 list of outbreak viruses in Africa. What are some of the countries this is endemic? Are there different strains of this, and how does it affect the population and why and the way it's spread? Has the CDC, that's Africa CDC, secured or in the process of securing vaccines for affected areas? So those are 2 questions from Zain and from Lisa. Over to you, Prof.
Thank you for those 2 last but not the least questions. So on the side of the spreading differently of Mpox in West Africa, the more we go, the more we learn. In the East Africa, it was clear that one of the key drivers was the sex worker and the truck driver and so on. Now, as Dr. Cheng mentioned, in Sierra Leone, we already starting with a different clade, the clade 2B, which already make a difference. But also when we look at the key population who are exposed and affected currently, we have the students, we have the traders, we also have some sex workers. So we need to learn more on the demographics so that we can identify clearly the drivers. And this is something that is being done. The team will be next week supporting the Sierra Leone on pushing the deployment of 200 community healthcare workers and field epidemiologists to better understand what is happening, but also to contribute to the early detection, the isolation, and also the targeted vaccination. So for measles, I will let Dr. Cheng answer.
So much, Prof. So for measles, since the beginning of this year, we've had over 16 countries that have reported outbreaks of measles. Again, measles is kind of endemic in most of the countries on the continent, but the countries that we're really seeing a huge outbreak that really needs attention includes Morocco, Ethiopia, DRC, reporting the highest numbers, Somalia as well. And if you look at some of these countries like Somalia, DRC, Ethiopia, they are all happening in the context of, forced displacement, insecurity challenges and all those. And recently our team were on the ground in Ethiopia really supporting vaccination campaign against measles. And this is something that we think we really need to replicate in other countries that are really experiencing these huge outbreaks. But again, the fact that we are also incorporating continuity of essential health services in our response strategy also just ensures that we have this routine immunization, especially for children and women, really prioritized and not interrupted during our outbreak response. Back to you.
Thank you very much, Dr. Mercy and Prof. Yap, for taking on the section for today. As we draw the session to a close, we want to thank all of our colleagues, the media, the journalists, and everyone who has participated actively into this section. With that, I will turn over to Prof for the parting comments from the IMST before we close the section. Over to you, Prof.
Thank you so much, Nick, for the good moderation of today. So this morning we have the Emergency Consultative Group, which advised the Director General of Africa CDC on the criteria to carry on with the FEX, the Public Health Emergency of Continental Security. So they discussed during 2 to 3 hours, and then we expect to get the advice on whether we should continue with the Mpox as a continental emergency of security or whether we should leave. So as soon as we have the information, definitely it will be made available to you. They also promised to meet prior to the month of June to discuss cholera. As mentioned, cholera is spreading in many countries. So it might also meet the criteria to become a FEX, but that will be to the expert to decide. However, the head of state will be meeting in the first week of June to discuss the issue of cholera. This will be championed by the president of Zambia, which is a champion on cholera, to ensure that we have that strong leadership at the highest level. As we mentioned, cholera is not a disease only due a medical disease. It also have many other areas that need a stronger leadership. Now, to conclude, I will really thank the journalist. We did a social behavioral study in 9 countries. And some of the preliminary data that we have is that 1 out of 100 persons that has been studies have a full knowledge on Mpox. 2 out of 10 respected the Mpox prevention and control measures. So we are really far from where we want to be. But what is interesting is that 70% of those population trust TV, when 30% of those trust radio, and 22% of those trust the social media. So you are actually the key player on sending the good information for our population to have the right awareness, to change the behavior so that they can adhere to the response and ensure that we stop the transmission of the Mpox and other outbreaks in the continent. So as we move forward, we need to do more. We need to do better with less. And we count on you, the journalists, but also on all the colleagues who are in all those countries fighting against those high emergent events. Thank you.
Thank you, Prof. No better way to end today's briefing, but a call to action for everyone's action to help us in our own communities. Thank you. We see you next week, same time, just here on Zoom, live with Africa CDC.